Very good evening to all of you. So welcome everyone to yet another Vertigo Grand Rounds. Today we have Dr. Yogesh. Okay, so Dr. Yogesh finished his ENT from Gangaram's, New Delhi, and now he is running his own practice along with being in. So he has a keen interest in Vertigo, and he's been one of our alumni of assessment and management of vestibular disorders course. Okay, one of the star alumni. And along with Dr. Yogesh has made some key contributions which I am aware of. One of these is that he has a very beautiful collection of videos which come as for acute vertigo rehabilitation of a person after an acute unilateral vestibular insult. That is one thing that he has done. And the other thing, and that it's a set of detailed instructions and set of exercises which run over 30 minutes. The video runs over that. He's contributed to that. He's done very wonderful work there. The next thing is that he's also come up with a very beautiful pro forma. One of the difficult things is how to evaluate a person with recurrent vertigo. And, okay, what common diagnosis to consider and what diagnosis not to miss, and how to have a pro forma so that some of these diagnoses, rarer diagnoses, are not missed. So he's come up with that kind of a pro forma. I have, as the panelist after, along with Dr. Yogesh, who will be presenting, Dr. Pratik Porwal. Dr. Pratik Porwal is already very well-known figure when it comes to vertigo. Okay, so he has multiple publications. One of his star publication is with a lot of impact is his work on anterior canal. It's a multi-center study, but then he has analyzed everything on anterior canal benign paroxysmal positional vertigo. Okay, people in DNB know him as one of the co-founders of the DNB Mentors, which is a very successful platform which helps in learning. Okay, so with that introduction of the presenter, Dr. Yogesh, and a panelist, Dr. Pratik, we will be starting off. I'll hand over the stage to Dr. Yogesh. Yogesh will be sharing the screen and he will be presenting the acute vertigo pro forma. And after that, not the acute vertigo, I mean the recurrent vertigo pro forma which he has made up. Following which Dr. Pratik will be sharing his insights in how these things have been useful in his own practice. Okay, thank you all. Thank you so much. So now I will I will request Yogesh to start sharing his screen. Yes, Dr. Yogesh.
Yes, sir. Good evening, everyone. I am Dr. Yogesh Kotwani from Bilaspur, Chhattisgarh. I'm immensely grateful to Dr. Srinivas for giving me this opportunity. It's an honor to be here. As the topic suggests, I will be discussing the pro forma for recurrent vertigo. When I was working with sir in Bangalore, I used to ask him every time that how to remember so much information or how to rule out so many diseases, how to proceed with this diagnosis and management of vertigo. So he always used to tell me, don't try to memorize it or don't try to memorize anything, just make pro formas and relax. So using that funda and using the book Dizziness which he suggested, I made this pro forma. Now we will begin with the pro forma. Now, as I will discuss, we'll start with the usual name, age, sex, occupation, or any chronic drug intake history, any vascular risk factors. Okay, you may notice here that I have used number 9 in the vascular risk factor heading. Now I have used these numbers to give you an index. This is the index. This is the index. Basically, by using many questions in history and using different examinations, we can write the numbers which that examination suggests. Like if we find 5 positive findings in history and examination, and all 5 suggest for number 5, so it might, the diagnosis might point to Meniere's disease. If we find 10 different numbers, but 8 are 5 and 2 are 6, so number 5 indicates Meniere's, but there might be a hint of vestibular neuritis. So using these proformas, these 17 diagnoses can be cut down to only 1 or 2. So that in that way, I have made this proforma. So I will start with this. We start with name, occupation, or any chronic drug intake history, any vascular risk factors like diabetes, hypertension, smoking, hyperlipidemia, which is suggestive of number 9, which is transient ischemic attack. Now, by history or by history, we will rule out if the patient is complaining of vertigo or if patient is complaining of dizziness. Now we know vertigo includes 2 sensations: sensation of self motion when no self motion is occurring, or sensation of distorted self motion during an otherwise normal head movement. While dizziness, it is the sensation of disturbed or impaired spatial orientation. So we have just, I have just distinguished between 2, but we can take the complete history of both vertigo and dizziness also. So we'll start with if complaints are of vertigo, then we'll find if there is any history of similar vertigo in childhood, which is suggestive of vestibular migraine, because benign vertigo of childhood are usually the precursors for vestibular migraine in adult. Then we'll move on to how many episodes per day. If there are many brief episodes per day, it might be suggestive of number 1, which is vestibular paroxysmia. Now, what is the duration of each episode? We know the duration might be in seconds, minutes, hours, or weeks, which is suggestive of different diseases, as we already know. Now, total duration of complaints, if more than or less than 6 months. If there are complaints are of more than 6 months, then it means it is not TIA. And it is less than 6 months, it might be TIA also. So number 9 is basically TIA. Now, is there any history of migraine or associated migraine features like headache, photophobia, phonophobia, or aura? How is vertigo started? Spontaneous or head motion induced, lack of sleep, any hormonal changes, or during menstruation, on seeing cinema, traffic, crowds, walking in supermarket aisle, or bilateral sound induced vertigo? So I've created this list so that we don't miss anything, or we can just mark or ask the patient properly. Now, is there any position induced vertigo? Now, position induced vertigo, we know it is most common because of benign paroxysmal positional vertigo, but there are other causes also which I have mentioned here, which should be ruled out, like vestibular migraine and vestibular paroxysmia also. Now we'll ask any aura before attack. We can ask regarding aura, any scintillating scotoma, any wandering unilateral paresthesia, unilateral weakness, aphasia, any zigzag lines interfere with reading, which is suggestive of vestibular migraine. Now, is the vertigo elicited by strain or barotrauma or loud sound or any pressure changes? Then it is suggestive of perilimb fistula, which is number 11. Now, any eye features of keratitis, which is a part of triad of syphilis. So syphilis also has ear complaints and vertigo and eye features of keratitis. Now, any history of any vesicular rash, ear pain, or facial palsy, which is suggestive of varicella zoster or Ramsay-Hunt syndrome. Any history suggestive of anxiety disorder or depressive disorder, we'll manage it accordingly. Any hearing loss. If there is hearing loss and it is consistent or fluctuating, which might be part of vestibular migraine, vestibular paroxysmia, Meniere's disease, or perilimb fistula. Now, any tinnitus or any oral fullness, these all 4 diagnoses are possible in this. Now, is there any cochlear complaints are unilateral or bilateral? If there are unilateral, it might be suggestive of acoustic neuroma also. But if they are a bilateral, then the above mentioned diagnosis and also autoimmune inner ear disease, we should not miss. If the cochlear symptoms are present, then the sequence of cochlear symptoms with respect to vertigo should also be seen, which is suggestive of number 5, which is Meniere's, or any residual tinnitus or hearing loss post attacks is present. It is also suggestive of Meniere's, while the burnt out Meniere's means the cochlear function is almost completely lost. So the residual hearing loss might persist after many years. Now, progression of hearing loss, if present, it is rapid or gradual. Gradual is seen in many years, but rapid progression within weeks or days, then it might point towards autoimmune inner ear disease. Now, is there any history of sudden falls? If there is history, yes, then we have to look for it is with loss of consciousness or without loss of consciousness. If it is with loss of consciousness, it might be pointing towards number 9, which is TIA. And if there is with loss of consciousness, then it might be due to Meniere's disease. Now, does complaint resolve completely in between or not? As the history of TIA suggests, the complaints get resolved in between completely within seconds to days. Now, if there is complaints of dizziness, then we have to look out for the risk factors. Is this old age, dehydration, or any hypertensive drugs? Because most common culprit of dizziness in old age or dehydration or hypertensive drug is orthostatic hypotension. So we'll ask history regarding that. Dizziness lasting seconds to minutes after standing up. So it might point us towards orthostatic hypotension. Now, dizziness lasting seconds accompanied by palpitations, then it might point us towards arrhythmia, which is number 14. Now, dizziness lasting minutes to hours associated with situation like crowd, height, supermarket, or associated with choking, palpitation, tremor, it might point us towards number 3, which is panic attack. Now, if there is any lightheadedness or faintness, it might point towards a 14, arrhythmia or cardiac disorder. Any prolonged history of drug intake we should not miss, because it might help us to diagnose orthostatic hypotension for hypertensive drugs, arrhythmias, and also ototoxicity. We should not miss any history suggestive of ototoxicity. Now, any history of heart disease or any history of fear of impending doom, trembling, or shortness of breath. Now, we'll start with the clinical examination after a detailed history. Now, we'll look for the pulse. It might be normal, it might be brady or tachycardia, which will help us to rule out arrhythmia. We'll take BP. We also take blood sugar random. Now, some points in this clinical examination I have taken from SIRS acute vertigo proforma, which I have used here also. So we'll examine voice, which might be normal, hypernasal, or hoarse. We will examine speech, facial movements, tongue protrusion, and soft palate, basically to rule out TIA or neural involvement. We should not miss the ear findings, because our DD also contains perilymph fistula. So we'll examine complete ear examination of pinna, EAC, tympanic membrane, attic, mastoid, and hearing. For hearing, we'll use tuning fork tests or Rini Weber, and we can predict the type of hearing loss. Now, again, I will use the nystagmus. Nystagmus is basically spontaneous and gaze induced. Now we'll look at center, we'll look at 30-degree right, 30-degree left, up gaze, and down gaze. Now, gaze evoked nystagmus might suggest cerebellar lesion, number 13, or we also would like to see which follows Alexander's law. So that is, intensity increases on looking the direction of nystagmus. If it increases, then it might also suggest us vestibular neuritis here. Now we'll look for pursuit clinically, which vertical and horizontal, which might help us to diagnose vestibular migraine. Now we also will do head shaking nystagmus. Now head shaking nystagmus is basically we shake the head of patient for 30 seconds and then look for any residual nystagmus. This basically brings out the hidden nystagmus, which is due to vestibular neuritis. Now we'll make the patient stand up with eyes open, normal standing, stand with minimal support, and to further decreasing the support to rule out cerebellar disease or the acoustic neuroma. We should also mention the right direction of pulsion, which helps in diagnosing vestibular neuritis also. Now, most important test which I have found is a head impulse test, which helps us to diagnose unilateral or bilateral vestibulopathy, especially during post vestibular neuritis. We'll also go for hyperventilation, which is for 60 seconds in adults and 30 seconds in extremes of age. And we'll observe for 1 minute for any nystagmus. Now, this helps us to rule out acoustic neuroma, vestibular paroxysmia, and orthostatic hypotension also, which sometimes have hyperventilation-induced vertigo. We'll do fistula test, which is negative, which is rarely positive, but we'll try to do this. We'll also try to do Valsalva induced vertigo, which might help us to point towards perilimb fistula. Now, two tests which sir has mentioned earlier, two parts, two sensations, both sides. Two parts are face and body. Two sensations are fine touch and temperature, and two sides are right and left to rule out dorsal column, cerebellum, and TIA and acoustic neuroma. Now, we'd also like to do Babinski sign for TIA in case some residual meningism features are there. Then we'll move on to McClure-Pagnini supine rolled and Dix-Hallpike test. And we'll also look if there is persistent nystagmus or crescendo decrescendo pattern is there. So for BPPV. Now we'll rule out orthostatic hypotension by taking BP in supine position in 1 minute after standing, 3 minutes after standing, 5 minutes after standing, and 10 minutes after standing. And if the BP falls in systolic or diastolic, then we can label that patient as orthostatic hypotension. Now, to confirm vestibular weakness, we would like to go for cold caloric test, ice cold caloric test, which is usually done using 2 ml of 3 to 4 degree ice cold water. And we can find if there is left weak or right weak or both side weaks or it is normal. So we can confirm if there is any history of vestibular neuritis. Now, 3 basic lab tests we should perform, which is PTA, pure tone audiometry, thyroid levels, and electrolyte levels. Thyroid levels also are important because there is a prevalence of metabolic vertigo also there, and electrolyte levels. Now, the book also mentioned if we are not finding anything, then we should go for drug trial also, which might help us to diagnose the patient. We might go for migraine prophylaxis trial, or we might go for carbamazepine trial to look for vestibular paroxysmia. So in the end of the whole proforma, I've added the index so that we can put all the numbers aside which we found in our whole proforma, and we can see which diagnosis the patient is fitting into. I have also added 2 lists of vestibular toxic and cochlear toxic drug. I have derived this from Cummings and Scott Brown, just because I can't remember that much information. So I've added in this proforma only. So in this way, I have created the proforma.
Dr. Yogesh,
Yes, sir.
this proforma is actually very good, and it will help us, like practitioner who don't have much time or who don't give 30 minutes or 40 minutes to the patient. So, but I would like to add few things.
Sure, sir.
So, very good evening to all of you. My name is Dr. Pratik Porwal, and with permission of Dr. Srinivas sir, if I can add something.
You are always permitted. First and foremost, doctor. First, let me. My internet dropped off, so I just logged in and logged out at the last moment. Okay, it's a wonderful proforma which Dr. Yogesh has done, and the concept is very nice. Like questions are there, and then there are numbers by the side of the questions. At the end of the questions, you just collect which numbers repeat most commonly, and then that will point us. Like he has written this for a computer program. Somebody who wants to make a program to give a diagnosis. Okay, this is what they should be looking at. Thank you so much, Dr. Yogesh. Okay, that's a wonderful proforma. A lot of points are there. So as things,
Hannah?
Okay. Yes,
Yes.
Dr. Pratik. Now you can go ahead, please.
So, Dr. Yogesh, can you go to the first page?
Yes, sir.
Yes. So I would add few things. Okay. So name, age, sex, occupation. Occupation is actually very important. And in all the patient, you have to specifically ask what is your occupation, especially the night workers. So it might give you a hint of stress or a hint of migraine and other things. And you have also added any vascular risk factors in which you have asked about diabetes, hypertension, smoking, hyperlipidemia. I think you should also ask, and everyone should ask the history of alcohol intake, because most of us don't ask it, and to both males and females, you should always ask for a history of alcohol and how much he or she is taking. And that you might get that on every test is normal, everything is normal, VNG is normal, history is non-specific. But if you give a vitamin B1, that is thiamine, you will see that the patient will respond. So this is my first point. Second is, if I'm coming to the complaints part, if history is similar of vertigo in childhood. So in this point, see, not every childhood problem is vestibular migraine. If you are suspecting any child of vertigo or dizziness or anything, if he is coming to you, you should always rule out any history of seizures. So you have to do a EEG, electroencephalograph. You have to do. Second is, migraine has, like, there are so many varieties of migraine. We cannot just always say that this patient is suffering from migraine. So we have basilar migraine, we have migraine with headache, we have migraine associated with anxiety, and we also have few channelopathies like episodic ataxia. And I remember a patient from Jammu. So this lady was of 20 or 22 years old, and whenever she travels, like if she has to go to give an exam in her college, she used to travel 4 kilometers on foot. So after giving the exam, when she is coming back, the night will be very terrible for her. So she will feel like everything is gone. I'm feeling very dizzy and all. So on taking detailed history, we found out that this patient might be suffering from episodic ataxia type 2. So the hint is not in this patient, but in other patients. If a patient is going to gym or if he's doing a very heavy physical workout, like traveling or anything else, and it is getting aggravated, and the age should be between 18 to 24. And if a patient is taking alcohol, after taking alcohol also the patient will feel like these symptoms, like I'm feeling very tired, I don't want to get up, and I want to sleep all day. These things also can be seen in patients with episodic ataxia. And by just using one trick, you can find out whether he is suffering from episodic ataxia or not. If you give escazolamide to the patient, I think just 2 doses, you will get a better result. Or the patient will say, "Sir, I'm feeling good." So this is one thing I wanted to add. And you have also written about this visually induced or vertigo, which is elicited by a big background or a different colored background or zigzag patterns. So this is not always seen in vestibular migraine, but it is majorly seen in vestibular migraine. And you can also see these kind of symptoms in patients with otolithic dysfunction. So they will always say that I'm tilting to one side, and when you are doing the subjective visual vertical, everything will be tilted to one side. So this also you have to keep in mind. Third is anxiety and depression. And you have not given any number to this depression and anxiety. According to me and the patients which we have seen in Bangalore since 3 years, I think most of the patients, either BPPV or migraine or triple PD, they all have some component, either anxiety or depression, or they have a stress or any concealed feeling about their family members and all. So you have to take very good history, and this anxiety and depression can be seen in any patient, not just migraine patient. It can be seen in triple PD patient, uh, BPPV patient also, and patients with this Meniere's disease also, because they are not getting treatment anywhere.
Yes.
So, so you have to be very cautious. And if you are just giving the treatment for migraine and you are not giving treatment for anxiety or depression, or you are not counseling the patient, then your treatment might fail also. So this
Yes.
point you have to see. And coming to, can you go to the next page?
Yes. Sure. Sure.
Last point, any history of sudden falls. So falls is a very big topic. And falls can be seen in patients with BPPV also. That is why we hold the patient's head, hand after doing a freeze maneuver.
Yes.
If you're not holding it, you have to start holding it. Because once the particle is entering the utricle, he might feel a sudden lateral pressure. So some patients will come to you by starting, sir, I had a fall. Last day I had a fall, and when you are doing a positional test, you are seeing a posterior canal or any type of BPP. Falls can also be seen in Meniere's disease, which is very most commonly seen. You can also see falls in patients with vestibular migraine. Yesterday only I saw a patient with vestibular migraine, full sweating, uh, but there was no loss of consciousness. And then we have to start RL, we have to admit, and we have to start RL, etc. This fall can also be seen in patients with autolytic crisis, and these patients are very difficult to diagnose first. One, yeah. So falls is a very good history you have to take. BPPV, Meniere's disease, migraine, and autolytic crisis. Patients can present with falls.
Yes, sir.
Then coming to this lightheadedness and faintness. So you have written 14. What is 14, Dr. Yogesh?
14 is arrhythmia, sir.
Arrhythmia. Okay. So if you remember, like Srinivas sir
It's
has
called-
shown some videos, like 1 year before, like the patient is falling or some policeman is falling.
Yes, sir.
So this lightheadedness and
Conscious.
faintness can be seen in many patients.
Yes, sir.
Most commonly is syncope. Syncope
Yes.
can be seen in females, in children, in old age patients. There are few cases which we have seen in which patient is passing urine and he fell. So lightheadedness, syncope, you have to rule out. You have to always see. If you need, you have to go for a neurology opinion also.
Yes, sir.
Syncope, you have to always remember.
Yes, sir.
And coming to drugs, you have written. So what are the drugs which we have to see? You have told about vestibulotoxic and cochleotoxic. Any other drugs which you want to add?
For hypertensive drugs or any drugs which might precipitate arrhythmias also.
Hmm. So what we have seen is, I remember one patient from Dr. Vijay.
उसमें फायदा आप
Hello.
भी
So,
Hello.
बहुत साथ यार महीने का क्या
Vishnu? Vishnu?
uh,
Vishnu, can you take care of that mic? I think there is somebody unintentionally talking.
Yeah, sir. I'm trying to mute them. It was not.
Okay,
no problem.
Dr. Pratik.
Okay, no. So coming to drugs, in this you have to also include alcohol. First, second is I remember a patient from Dr. Vijay sir. He was a like 14-year-old person, and he was having a congenital, not congenital, a pendular nystagmus. So when we did a VNG, we saw like every other thing was normal. Just he is having a pendular nystagmus. And on taking the detailed history, we found out that this patient is also taking anti-convulsant medication. On removal of that particular medication,
Vishnu,
Yeah,
please
sir.
you have to
I'm
take
trying
care
to
of this.
mute them.
Otherwise, mute everybody and then unmute the speakers.
It is not getting muted, sir. That's what I'm trying from that time.
I muted off.
yes, sir. Am I audible now?
Yeah, you are audible.
Yes, sir.
Yes. So I will repeat again about drugs.
Yeah. Yeah.
So first thing is you have to include alcohol in drugs. First thing.
Okay, sir.
Second is you have to take care of. You have to see the prescriptions, what patient is taking also. So I remember a patient from Dr. Vijay sir. A boy, like 13, 14-year-old boy came to us with vertigo, and we did a VNG and we saw that there is a pendular nystagmus, and nothing else was positive other than this pendular nystagmus. So when we stopped, when we asked sir whether to continue this medication or stop this medication, when we stopped this particular medication, the pendular nystagmus went off, and the patient was very good. He told that, sir, you have done very good, and I'm feeling better. So every medication you have to write what medication the patient is taking. Another is this Temetel or prochlorperazine. This is very notorious drug which will cause drug-induced vertigo or drug-induced Parkinson's. So many things. This metoclopramide, this everyone is using this Pantop DSR. So in my practice, I'm not using a single tablet of Pantop DSR or any PPI with DSR because I know in an old age person he might be taking it, and I don't want to like worsen him. So prochlorperazine you have to use. You have to think DSR, any tablet with DSR or metoclopramide, you have to check. Second is gabapentin. Most patients are taking 3-GABA for backache, lower backache, and for other things, any kind of neuropathic pain, etc. Gabapentin is very notorious for producing a downbeating nystagmus. You are doing a positional test, you are doing a disulfide test, and you saw downbeating nystagmus. Immediately you saw, oh, anterior BPPV. But when you are doing a Bangalore maneuver or Yakubino, it is not going to resolve. Gabapentin, then carbamazepine, this might cause a gazebo nystagmus and lot of swell ruptures. Carbamazepine also you have to ask for every patient. And then very notorious is antipsychotic drugs. If a patient is taking and the patient is feeling vertigo or feeling dizziness, then you have to talk to the neurologist so that we decrease the dose. You can ask the neurologist, sir, can we decrease the dose so that everything is balanced out. So these are few things which I would, yes, these are the things I would like to add.
Okay, Dr. Pratik, thank you very much for adding so much of specific points to the pro forma that Dr. Yogesh presented. Okay, so in fact, alcohol was one thing that we were not asking very often. Only after you came, we started asking very often now. And now in Bangalore, like every day, we are asking every person about history of alcohol intake. So basically, now when we are clueless in a patient, two things we think of. One is if the person lacks what the person needs, or the person is getting something that the person doesn't need. Lacks the person needs is like there are micronutrient deficiencies which we always need to think in terms of, okay, there are simple magical things that can happen with supplementation with thiamine, especially injectable thiamine. Magical things that happen with omega-3 fatty acids being started. Magical things happening because of single amino acids, which we are trying to replace for a lot of patients. That is one beautiful thing. That is actually the therapy part. But the more important part when it comes to today's point of discussion is the evaluation. And when you pointed out so much about drugs, yes. So the person is actually having or getting something that the person doesn't need. So on one side, the nutritional deficiencies or not having something that the patient needs. Here, the patient getting something where the patient doesn't need. From alcohol onwards, with all the different kinds of drugs. In fact, reviewing the drug as a separate part of the protocol. Drug review should be given the same importance as, say, probably one part of the vestibular investigation. If somebody spends 20 minutes doing a VAMP or 30 to 40 minutes doing a video nystagmography, another 20 minutes doing a pure tone audiometry, in any case, patient is spending 2.5 hours in your center. Why don't you spend another 15 minutes reviewing the drug and do an online interaction check or do a check for what they are likely to cause in an elderly patient, and you will get the clue in a lot of patients. So that's a beautiful point. And Yogesh, it's really, there are a lot of chat messages coming up telling, congratulating you, and people are also asking whether this proforma can be shared. I think this proforma can be shared. What do you say, Yogesh? Free to use?
Yes, sure. Sure.
Yeah. So Vishnu, at the end of this, Dr. Yogesh will share the proforma. So whoever has asked for the proforma, or you can broadcast it to them. Okay. Or in the groups where we share this proforma, the invitation there, you can share this. Okay. So that is
Sure.
one. It's a nice proforma, very nice. The points and then adding up all the points. It's not exactly adding up, counting how many 14s came or counting how many 9s came to tell what it is. likely which comes the more. Okay. So this
Sure, sir.
yeah. So the proforma will be shared with everybody. Maybe if you want specifically, if by chance you don't get it, Vishnu will post his number now in the chat group so that he will do. There's one more specific question. Okay. Vishnu, you can put your phone number so that they can send a message to you, so that if they don't get it, you can always share. Okay.
Yeah, yes.
Okay. Dr. Anjana has mentioned tamsulosin for BPH. Yes, that's one of the things culprit which we keep coming across. Okay. There's one more question. Okay. Dr. Deepika has told congratulations to you. Dr. Anup Singh has nice question. In fact, I have this question also. How is the experience of seniors in this meeting about otosyphilis? Has anyone seen or diagnosed or treated a patient for this? As of now, I have not. As of now, anybody from the audience, anybody who has seen otosyphilis, if you want to just unmute yourself and you can say.
No, sir.
Okay, so I don't think. I don't know whether we had muted everybody to remove one noise, whether other people are able to unmute on their own, we don't know. If a problem is there in unmuting yourself, please put a text message here so that we'll specifically look into each one of you. Okay. Yeah, Dr. Chandrakant, yes. So Vishnu, put up your number there in the chat so that whoever wants the proforma will just message you to this number. Yeah, Vishnu. This is Vishnu's number. Okay, 895125528. You can just message there. You'll be sent the proforma. Okay. So anybody else wants to add something to this? Yogesh, if any further comments from your side after this?
No, sir.
After listening to Pratik?
I'll add whatever sir has said. I'll add to this and complete it. And also I would like to make one drug proforma so that I am able to remember all the drugs.
Oh, all the drugs. Okay. At least the common drugs. Maybe that.
Yes.
And when we actually start seeing there are not many drugs. Okay. People go through the same. Okay. Everybody comes with the same this thing. Many, Dr. Rajeshwari is saying many older age groups are on sedatives for reduced sleep. How to balance this with giddiness? This is a very, very important question. Your thoughts, Dr. Pratik? They're already taking
melatonin.
Melatonin. Yes, exactly. This is again what we started doing for a lot of patients, and we have a lot of patients who are so happy now. Okay.
Yes.
So the way to wean off from sedative drugs, other sedative drugs, and still allow them to sleep and still make them feel fresh, make their skin glow, make them look more beautiful is all melatonin.
Yes.
Okay,
Yes.
it's all more melatonin. They'll have a better outlook towards life. Okay, they'll start feeling a few years younger, and they'll sleep better. And then the other advantage is whatever the sedative drugs they were causing balance related problem, melatonin will not cause that. Okay, only thing is you'll have to two things in melatonin. One is you don't have to really start that full dose. Each person has their own requirement. Okay, that one. The next thing about melatonin is the person, when they should time it in such a way that when they start feeling sleepy, they should immediately fall asleep. They should not try to keep awake for whatever reason. If that happens, then the results are not there. In fact, it can be counterproductive. The moment somebody who is taking melatonin, the moment they feel the urge to sleep, they should immediately start sleeping. Okay, super. Any more questions? Dr. Dr. Pushpanjali is asking, sir, do add such proforma on the next update so that VNG and rest objective reports it get printed as first page. Uniformity across the national level on diagnosis and reporting under this new movement on balance culture. Excellent, ma'am. Thank you. So I think that is what is the attempt also. So what the beauty that is happening is with we right now AMBD a group of people. Okay, the magic is happening from you. Okay, from all of you who are in this thing now. Yogesh has come up with this proforma. Yogesh has also, what is not known, what I mentioned in the beginning, is his video on how to rehabilitate acute unilateral vestibular lesions. Okay, So that's another beautiful video. Maybe we'll include that in one of the upcoming Vertigo grand rounds. Okay, so that that can also be discussed. Okay, so like that, what will happen is, so with that, more and more things are going to happen, and more patients are going to be helped. Any questions or anything to be told from our participants who have joined in? Okay, please let us know. Okay, Pratik has mentioned in the chat box about the dosage of melatonin starting with 0.5, 1.5, and then moving on to 3 mg. Okay. Any more questions? Dr. Dhanya, okay. Ma'am, why everybody is sending message? Does it mean that you're not able to unmute yourself? If you're not, if anybody is having difficulty in unmuting yourself, please message here so that we'll make an attempt. One patient, Dr.
Sir,
Dhanya.
am I audible? Sir, am I audible?
You are audible.
Dr.
You are
Dhanya here.
audible. Yeah.
Yeah, I remember one patient, one Korean. He was having a lot of family issues and he was having melatonin. I was never prescribing melatonin. It was given by a neurologist. So he was not getting sleep even with melatonin. Since I was not familiar with the drug, like he needed a lot of counseling session, and he was having a background of migraine, and finally this particular patient slept afterwards. So that's my experience with
this
melatonin.
person did not respond to melatonin. The person responded to your counseling.
I don't know. No, sir.
Yeah,
I remember this patient, Korean. With melatonin,
I
he was
know.
not responding.
If there is complicated cases, which we all think at, okay, first line drugs, if they don't work, we will go for second line drugs. If second line drug also has not worked, if somebody has seen that patient, it is Dr. Dhanya who has seen that patient, in whom we have to see third line, fourth line, and all that.
Doctor, this
Thank
patient
you.
I remember with melatonin, he was not responding.
He was not responding to melatonin. Not everybody, but then if there is one way in which we can think of weaning off some of these other drugs, is considering melatonin as an option. Okay. But there are people who will not respond to anything for that matter. Okay. And as you said, with counseling helped, which means there was some clutter which needed to be released in his mind.
Yes, sir. Yes, sir.
Yes. Thank you, ma'am. Thank you so much. Thanks for adding that. Okay. So the beauty of this proforma is we started at 8:30. Proforma also got completed. Proforma related points also got completed. Additional discussion also done. This is how the proforma should be. When you talk about a proforma and discussing the proforma takes 3 hours, then implementing the proforma will take 6 hours and nobody will do it. Proformas have to be short, have to be small, have to be pointed. Okay, and only then they will become useful. Okay, that is the entire this thing. So previous to this, we had 2 proformas: acute vertigo proforma, predominant complaint of difficulty in walking proforma, those 2 proformas. Now we have this proforma. So in the days to come, I expect a lot of people to come up with new proforma for each condition. Maybe somebody will come up with a false proforma, how not to miss a single diagnosis of false, to at least to a great extent. Okay. Not telling that we'll not miss a single is challenging God, which is not correct. Okay, it's not possible. Okay, so but then I am sure that things will move in this in that direction. So I think with that, any final thoughts, Dr. Pratik?
Krupa this side.
Yes, Dr. Krupa.
Yes, Prabha.
Sir, hello Pratik sir. Hi Yogesh.
Hi.
Good evening, ma'am.
Sir, as we had mentioned, most commonly, of course, for drugs for benign prostatic hypertrophy, along with that, many times these patients are on Ayurvedic and homeopathy medicine.
Absolutely.
That is
Thank
one
you for
thing.
yeah.
Yes, sir. And another
Lot of people are also taking supplements.
Yes, sir. Yes, absolutely.
So we need to specifically ask. Otherwise, they will tell, "Are you taking any medicines?" Then they will tell, "Oh, Ayurvedic le raha tha, wo nahi bataya." Because they didn't even consider that as a drug.
Yes, sir. Sir, and one more thing.
Yeah.
Yes. So multi-prescription, just that. Multi-drug prescription. We have to scan thoroughly.
Drug duplication.
Drug duplication.
Yeah, Dr. Krupa is telling the same medicine would have been given by in 3 different places, under different brand names. Patient without knowing will be taking all the 3. very common with multivitamins, so it is very common. Okay, with pantoprazole, this is also possible. So drug duplication is something that we'll have to look for. As Dr. Pratik told, if there somebody is taking 2 DSRs, one pan DSR, another one more DSR, that's going to add to the DSRs. Okay, so drug review is very important. Okay, what the patient is having additional. And okay, one more thing is, in a recurrent vertigo, one thing that we need to keep in mind is, okay, Dr. Yogesh has made a mention of tuning fork tests on these things. Very, very, very important, especially with one patient whom I remember. He is actually vertigo, tinnitus, that's all. And then if you simply ask, it looks like, okay, recurrent vertigo, and then constant tinnitus, recurrent vertigo, something like that. Okay. And then he was sent as already diagnosed as Meniere's disease and whatever it is. Okay. It turns out the patient had otosclerosis. Okay, so otosclerotic inner ear disease or otosclerotic people presenting like Meniere's is common. It's not uncommon. Okay, so it's very important that we always remember that we are ENTs first, or whatever we are MBBS first, ENTs next. Okay, or neurologist next, and then we are vertigo practitioners. So our basic things should not be forgotten. Okay, so that is very important to keep a note of. Okay, there are some messages in the. Okay, Dr. Anjana, what is the sensitivity of Holter in arrhythmia? One patient came with typical history of heart block and fall with transient LOC, but Holter was normal. Ma'am, this Holter being normal is a big problem. I will tell you the problem of Holter. When it comes to this thing, there is one particular patient who had arrhythmia, okay, whom I know had arrhythmia, underwent a Holter, and Holter turned out to be normal. And I asked him, what exactly you did? Did you do anything? Your usual normal works that you used to do? No. The Holter person who came there told that lead should not go off. So you have to sit in one place. So for that entire monitoring period, the person ensured that there was no movement at all, and none of the arrhythmia was actually provoked during that period. So if that is the case, if somebody is having on old things with all dangling wires, and those wires are not well fixed, or they are coming off, or that doesn't know how to fix this, these are problems. Okay, so you need to actually, when we send the patient to the cardiac evaluation, at that time we will tell that they actually will suggest you a Holter. When they suggest you the Holter, you don't, if the person comes and tells you that this Holter has to be, it should not become loose, don't move around, then I will tell him, just send him back to his place. Don't take that person, go to a new person, different person for Holter. This has to be told. Okay, otherwise they will do a Holter, and that's it. We would not get a good enough result. So one is, it is possible that a properly done Holter also will not show, because in that 24-hour period, patient never got an attack. That's one more thing that to this thing. In fact, there are other techniques also for Holter. Dr. Sriram was mentioning in one of our previous meetings. Okay, so maybe one of these other options also we can consider. But other thing is, during that 24-hour period when that monitoring was done, 24 or 12 hour or whatever it is, was the thing, was the person's symptoms, did they come? If they did not come, then the person did not have and the Holter turns negative. Probably that adds a point that maybe nothing happened. Okay, like that. Okay. So supplements, okay, magnesium, yes, omega-3 fatty acids are there. Most of these things come as melatonins. Okay, coenzyme Q10 comes as as a combination in multiple of these drugs. In fact, we have a medicine which is magnesium with coenzyme Q10 with riboflavin. It's a fixed dose combination which we get. Okay, omega-3 fatty acids, multiple different combinations come, 500, 800, 1000, 1500, everything. Okay, maybe in the beginning you can choose the higher dose. Okay. Krupa, what is the omega-3 which we are writing now? Sumega. Dr. Krupa?
So omega soft, osmega.
Osmega. Okay, osmega is the one which we are writing. Okay, melatonin is again 0.3. Among the amino acid that are such kind of micronutrients, one thing is L-carnitine and L-arginine. These two things are very good. Okay, L-arginine comes as 3 gram sachets. L-carnitine comes as 500 milligrams. So these are the things. Yes, ma'am. Okay.
So one thing I want
Yeah.
to add, sir.
Yes,
If a
Dr.
patient
Pratik.
is coming to you like 3 times in the OPD,
Yeah.
and still you are not able to treat him, just
Hmm.
take the this tuning fork and check the vibration in lower limbs.
Yeah. That is there. Of course,
It-
that is part of the predominant complaint of difficulty in walking pro forma and or chronic dizziness pro forma.
Oh, yes,
Okay.
sir.
So I think today that did not mention because this is a recurrent vertigo pro forma.
Recurrent vertigo, yes, sir.
Yeah.
And instead of giving him tablets of methylcobalamin, just start IV. 3 doses and the patient.
Okay. Okay, that I'm a strong votary of intravenous parenteral supplementation. The reason is if the person could absorb enterally, then probably the nutritional deficiency would not have been so bad. Okay, there is some
Correct.
amount of absorption failure that is happening. So it is always better that we correct the deficit with the parental. Okay.
So even for thiamine, I'm giving IV.
Thiamine, we are all giving IV, no? We started off
yes.
IV long ago. So, in fact, at that time when you were in Bangalore, Pratik, we were giving only 100 mg.
So now I'm giving 300 mg 2 doses.
Now we have started 500 mg single dose. Okay.
That's
Okay. So almost similar. We are all reaching similar conclusion. And then those patients who get thiamine, the way they say thanks is like full of thankfulness they will be. Okay. When they get the benefit. Okay.
Sir, now you're giving 500 milligram single dose and then repeating monthly.
No, I'm giving 500 milligrams single dose, and if required, we will repeat the dose after a week. Otherwise, no.
Okay, sir, good.
Monthly, we have not yet started. Okay.
Yes, sir.
Dr. Sona Mohandas is asking, what about B12 mouth dissolving strips? I don't have a personal experience. Anybody else has a personal experience with B12 mouth dissolving strips?
It is also coming
Sir,
some nasal
for
spray
me,
also.
I remember methylcobalamin for me a good result. I remember one patient, like
Yeah.
I don't know how it worked. Like methylcobalamin, 500 milligram thrice daily. I give for 1 month.
Okay.
Like for some patient, it works very well, sir.
Okay.
And,
that is like when you're
according
clueless.
to-
Basically,
yeah,
you think of all these things.
Sir, and the thing is, vitamin B12 assay, right? For some
Yeah.
people, I used to do, but according to our neurologist, the assay may not be low always. Like the
Okay.
value, yeah.
Yes. Assays may never be low for a lot of these things. Okay. In fact, Dr. Chetna is asking the same question. Do you do serum levels of thiamine before and after giving supplements? I don't do, ma'am. And most of the time, okay, we really are not doing. Maybe it's a good practice to start thinking of doing them. At least we'll be able to publish those things. But as of now, we are not doing it. Okay. And Dr. Anup Singh is still, yes, ma'am.
Is there any experience with riboflavin? Because we suggest a high dose, right?
Now,
I've not never used
riboflavin.
it.
Riboflavin is giving a lot of good results now. In fact, our migraine prescription, if you ask Dr. Krupa now,
Yes, sir.
previously the most common prescription, first prescription for migraine patients used to be either flunarizine or propranolol. Then it used to be amitriptyline. Now in our practice, the first medicine the patient gets is magnesium. Second one they get is riboflavin. If they don't respond to magnesium, riboflavin, then only we think in terms of amitriptyline, flunarizine, propranolol.
In what
Yes, sir.
dosage you give, sir? Riboflavin?
Riboflavin 400 mg.
400. Okay.
400
It's
mg.
available as that much dose?
It is available as 200 mg. The brand name is Ribofem. It's available as 200 mg. So we give BD.
Okay, sir.
Okay. Dr. Anup is asking, when do you suspect or how do you suspect thiamine deficiency? As Dr. Pratik told, first and foremost is alcohol. If there is a history of alcohol, but that is not a must. Then there are people who do a lot of fasting, intermittent fasting, 10-day fast, 3-day fast, 5-day fast, all different kinds of fastings are there. Then there are people who have been whose symptoms have begun after a period of hospitalization. These are the times when this marginal thiamine deficiency will become worse. Then there are people who are like all the time in a haze, some kind of dullness. Okay, the head is always dull. I don't know. Okay, lost interest in life. That kind of a feeling, even in them. Bilateral gaze evoked nystagmus is one place where again we think in terms of thiamine deficiency. So like that. There are like, and sometimes if you are clueless and you have nothing to offer them thiamine. That's all. So, and then see the result sometimes. Okay. So I think this was a wonderful discussion. Okay, 8:30 to 9, almost 9:25. I think all the questions in the chat box are answered. Okay. Chetna madam, I want you to unmute yourself.
Yeah, tell me. Hi.
Yeah, just unmute yourself and talk. That's all. After a
Yeah,
long time, we are seeing you.
a different look. Yours
Thank
is
you,
a
ma'am.
different look.
Yes, ma'am.
Yeah, long time, I know.
You are in Goa, so you will be needing more and more of thiamine for your patients.
That's what I was thinking.
Yes,
That's
ma'am.
what
Yeah.
was going on in my mind. I
Yes,
was
ma'am.
not vocal about it.
Yeah. Yes, ma'am. Sure, ma'am. Sure, ma'am.
Yeah.
Yes, ma'am. So thank you.
Thank you so much. It was a
Thank
very
you, ma'am.
nice session. Enjoyed it. Yeah,
Thank you,
thanks.
ma'am. Thank you.
Thanks.
Thank you. So thank you all. Thank you, Dr. Yogesh, and thank you, Dr. Pratik, and thanks for everyone for joining this session. Thank you all. Thank you so much.
Thank you, sir.
Thank you.
Thank you, sir. Thank you
Thank
very
you
much.
for the wonderful
Thank
session.
you, sir.
Thank you.
Yeah, seeing Pratik sir after a long time.
Okay,
Yeah,
he
yes,
will.
ma'am.
Yeah, sure.
Congratulations, Pratik sir, for the session
Ah.
also. And
Thank you very much.
For the baby also. Okay.
yes, new father. Yes, sir.
Yeah, congrats,
you.
Pratik sir.
Thank you, ma'am. Thank you.
Thank you.
Yeah, Pratik, congrats.
And congratulations,
ma'am.
Dr. Yogesh.
Thank you so much, ma'am.
Good evening, Chetna ma'am.
Thank you.
Evening,
evening,
good
ma'am.
evening.
Good evening. Thank you. Thank you all. Thank you all.
Thank you.
Thank you very much, sir.
Thank you all. Thank you all. So I think with that, with all your permission, we will end this session. Thank you all. Thank you so
Okay,
much.
sir. Thank you very much, sir. Good night.
Thank you. Thank you.